Then you, okay, there's a groin and abdomen, no problem. I will agree with what you are saying. You are not a layman, but anyhow.
And yeah, we are addressing those people who are trying to get into the profession.
Hi, layman. Anyhow.
So now you've done surgery in one of the tertiary hospitals that have no limit with the resources, no limit with the knowledge. Like, you need it, you kind of get it.
Yes.
That is the AKUHN University.
Yes.
You finished within 4 years, right?
Yes.
Then when you are done, what next?
When I was done, a colleague of mine called Dr. Nyaoncha, who is now a neurosurgeon in Nyeri, and left for training in the UK. And when he left, he had mentioned to the leadership or management in Consolata, where I did my internship, oh, there's a guy, he is finishing, if you're still looking for a general surgeon, you could reach out to him. So the CEO had reached out and I had told him, just give me some time, let me finish and do my exit exam, clear with Aga Khan, and then I can come, we talk. Once I was done, I drove down to Nyeri, we had a talk. And I got an opening and I started work there as a general surgeon. Then I was a senior registrar, so I waited for my specialist certificate. And I started with Consolata again now, Consolata Season 2, as a general surgeon in 2017 January.
So as a general surgeon, do you still also go for fellowship?
Yes, you can. You can do fellowship, and you can do fellowship in different ways. If you look at some training colleges, for instance, the COSEXA College, which is the College of Surgeons of East Central and Southern Africa, they're able to give you a fellowship. So I actually sat for the fellowship, but they tell you, they call you a fellow in general surgery. So now you become a fellow in general surgery. If you want, there's another fellowship which is more or less like recognition, and that's, for instance, the American College. So you can become a fellow after some thorough vetting, a fellow of the American College. These become like a rubber stamping of authority, quality, and expertise, where they admit you as a fellow of the college. For instance, I am a fellow of the College of Surgeons of East Central and Southern Africa, and I'm a fellow of College of the American College of Surgeons. Then there's another aspect, again, that comes into discussion when you're talking about fellowship. What is fellowship in the practice of surgery? It is a subspecialty, short course, hyper-concentrated training in one area. So for instance, if I now want to, again, subspecialize, say, in liver transplant alone from general surgery, or liver, biliary, and digestive problems, then I can say, I want to do a fellowship in hepatobiliary, hepatopancreatic and biliary surgery or something like that. So that's the other perspective. So fellowships are two perspectives. So I decided I'm not going for that yet, because I wanted to do 1, 2, 3 things. Yes.
So many years ahead. So as a surgeon on daily basis, what are some of the challenges you encounter and what things will you desire to change?
The challenges can be summarized with one word: more. So as a surgeon, you need more. You need more human resources. You need more resources in terms of supplies. You need more resources in terms of infrastructure. You need more resources in terms of system support. You need them from that spectrum. And that cuts across whether you're in a public, in a private, or in the faith-based, which is the bridge in between. So that is a constant challenge, because as a country, we still have a long way to go. When you look at our projections, we say, according to the Lancet Commission, you should have 20 surgery, anesthesia, and obstetric care providers per 100,000 population. Yeah. If you look at the concentration in Kenya, it's 2.3 per 100,000 population. So you see there are those other 17.7 who need to be trained per 100,000. So if you divide the 50 million by 100,000 and multiply by 17, you have your answer. So we've got lots and lots and lots of places where we need to take surgeons, and we've got a lot of equipment that we need to take to the surgeon, because if you put the surgeon there and you don't give them the equipment, then you invite frustration and you invite poor job satisfaction, and then they either do the rural-urban migration or the brain drain, which is either internal or they just fly out
for sure
to areas that can remunerate them better, support them better, and equip them better.
That's true.
So that is a constant daily challenge. And I know I speak for the surgeons of the Kenya, though not sanctioned, but I know they share that observation.
So if for example, somebody is desiring to be a surgeon, what do you advise are the best qualities of somebody who really wants to do surgery as a specialty?
Prepare. I would like to pick those movie one-liners when the plane is about to crash. Brace for impact, you know. You want to prepare to be a surgeon, brace for impact. No, surgery is a very, very fulfilling career.
Yes.
Very, very fulfilling career. But the training to be a surgeon takes you to the extremes of physical and emotional endurance. So it literally takes you blood, sweat, and tears, because while a colleague who is maybe studying a discipline that is not interventional, maybe they will need to write the thesis, maybe they will need to read, understand, see patients in the clinic and see patients in the ward round. So we can read around a condition, all of us, within 8 hours it has taken us 8 hours to understand how the condition presents, how the patient presents, how you investigate, how you make the diagnosis, how you treat them.
Yes.
But if you are training in surgeon, you have to add an equivalent 3 times of that time now to master the technique of doing that surgical intervention for that problem. So therefore you are called upon to be in theater longer, in the hospital longer, as opposed maybe to colleagues in other disciplines. So people must be willing, if you want to train as a surgeon, you really must be willing to dedicate your time, especially your time to the surgical patient. Yes, that is one. Number 2, there was this question about who is a good doctor, and I remember one of the lecturers again in undergraduate telling us, a good doctor is actually not the bright one who will pass the exam. We don't doubt that you can pass an exam. All of you and A's, all of you are in the newspapers. We want someone who is available. Because if a patient is dying there and you're not available, your skills really do not even apply now, because what value are the skills if you're not coming to save the patient's life? So availability is important. Availability is vitally important.
Let's talk about the enthusiasm of putting quality and patient safety in healthcare. When did it develop and what motivated it?
When I was in training, during the first year, we went through the first round of JCI accreditation, which was the initial one. There was a lot of talk and meetings and emphasis, and everyone is just talking about it. I remember then CEO coming and telling me, I can feel it in my heart. We have gotten this thing. Her name was Asmita, I think, Asmita Jilani, if I'm not wrong. And I didn't quite really understand what is all this. And then that first year came. Then as I was chief resident waiting to exit, the second cycle came. And now I was at the center of it, because you have to manage the rest of the teams.
Yes.
And make sure that in the department, if you want the handover forms, where are they? Show us, because you are the chief resident, now myself, Kobe, and Dr. Mayabi. And that's when I asked myself, so what does this mean then? Surely it can't cost us all the money and all this hullabaloo if it means nothing. And then it started making sense.
Yes.
But the real crystallizing of the need for quality is when now you go, there's this mantra that you don't know what you have until you lose it.
Yeah.
It's when you're thrown into the deep end and you are the sole person and you look at a treatment sheet and you're like, what is this now? Why did they just write this? You look at the operation notes and, my consultant used to tell me, my friend, by the time you become a consultant, you just be putting a full stop. Like, even the young ones are just writing one statement. Like, there's a way you can describe it, because over time you come back and you want to intervene on the strength of the records you can look at, and you realize that the records are scanty. And this is when it dawned on me that, look, there's a reason why this is there, and it is there for the patients. If you look at maybe from the standards of JCI, they will quickly start with patient safety. They are focused on patient safety, because if the care is not safe, then why is it there? People are likely to die more in hospital than at home if you come and you don't put measures to take that. So I made it my responsibility to practice my own quality and advocacy on a patient-by-patient basis, one patient at a time, because the privilege you get then as a consultant is you have this subtle mentorship to your juniors that you don't even know. So when they come and see my notes are written nicely, they might not even know what that, they will just copy. They say, okay, let me just copy the way he writes. He writes here, date and time, he writes this, then he signs here, he does this. So they just write, probably they don't know. And then over time, you now maybe get a chance to tell them why we do this is because of this. So I did that at the front line. I was famous for, I was so obsessed with the surgical safety checklist. Every time we were operating, want to do timeout. So people didn't understand what is this timeout thing. So when I was leaving Nyeri, I remember them saying, we are going to print the WHO safety checklist and laminate it and give it to you. Because this is the thing we remember you with. And then when I went to Meru, I was given the mandate of quality chair, or the chair of the quality improvement committee. And therefore that kind of brought a regulatory or operational requirement for me just to initiate quality mechanisms there. And I found myself now not just practicing quality as a clinician on a patient-by-patient basis, but looking at how can we improve our systems to make sure that they adhere to quality, to make sure that they adhere to patient safety, and et cetera, et cetera. So I keep making noises and speaking every time there is someone to listen, because it is vitally important. Yes.
An age that litigations will catch up with us if we don't implement safety.
I know, and it's here, as we say, every system is designed to get exactly the results it gets. This is the concept that maybe we don't get a lot, that if a patient complicated, don't look at that nurse or that doctor. It is the hospital system. It has been said that way. It is the system in that hospital that led that patient to that complication. On another day, it was going to be another doctor, another nurse, another patient, but the system will lead the same patient.
That makes you so excited, me being one of the quality champions.
Yes.
When people do a blame, it's Dr. Stanley who didn't do this. It's not Stanley. It's the system that has.
Absolutely. And you see what happens is if you allocate blame, you are not safe. If you read Complications by Atul Gawande, is my alter ego. I've read all his books, brilliant general surgeon in Massachusetts and a lecturer in Harvard. He talks about the sanctity of the Mortality and Morbidity Conference. Because what he says is, if you look at the aviation industry, which is where we've borrowed most of our safety checklist and quality from, or from the manufacturing, we are thinking about Six Sigma or Lean and all that, because different methods render themselves in different areas of the industry, you will realize in the aviation industry you're on the black box. But what is the black box in healthcare? The black box in healthcare, that can only happen if you assure your people that when we do a root cause analysis or a morbidity audit, we are not fault finding on individuals, we are fault finding on the system. So everyone will be forthcoming and saying, here I should have done this, here I should have done that. That genuine ownership and reflection, where people own up and say this is where the problem is, that can only come if you create a culture of safety.
For sure.
The litigation attorneys will not agree to that. The patients who come complaining will not agree to that. Yeah. But when you empower the healthcare provider to come and say, I am sorry, I made a mistake here, you have a safe system. And you have a system that can offer quality. The moment you want to pinpoint them, people will plug pages, write a perfect note. You will never find fault, but patients will keep dying. Patients will keep having complications.
Of the issues that we have.
Exactly. So that is sacrosanct. It has to be preserved. Because if we are under a black box, we'll have the black box. We just play it and it shows us who made the mistake, but we don't have that. We don't have that at all.
Sadly so. So in your day-to-day life as a surgeon, what one case that made you so sad that you can remember?
I won't mention the place, but I will mention the patient. This was a patient with intestinal obstruction, I think perforated bowel. I was called from town and I was told, we have this patient we have admitted, and this and this and this is the case. So I gave instructions to the intern and told them, you need to do this, you need to start this medication, start these fluids, put some tube, put some painkillers, and then let's give ourselves some time to resuscitate the patient so that they are strong enough to withstand surgery. Then I just wanted to drive to the house, just relax for a bit, and then wait for them to call me. And then one thought told me, just go to the hospital. So I passed by the hospital, and when I passed by the hospital, I came to look at the patient and asked them, where are the lab tests? And I found the lab tests. The patient has elevated potassium, what we call hyperkalemia. And I was like, before you do anything else, this very high potassium is going to give this patient a heart attack. And therefore, when I told them, come with a cannula, we fix there. I called the intern, come, let's pump fluids. And even as we were pumping fluids, I said, bring us calcium gluconate, which is one medication that you quickly use then to take down, to stabilize the heart so that the heart is not affected by the elevated potassium.
Yes.
But you've heard about look-alike, sound-alike?
Yes.
And you know what the look-alike, sound-alike?
What is
Potassium chloride. And it is drawn and it is in a syringe. So I'm told this is calcium gluconate and it's potassium chloride. So I gave, because it's supposed to be a slow push as we continue to resuscitate, but we lost the patient. And I could have gone and not understood what is the problem. But again, I just said, let's do a team debrief. So I gathered the entire team and told them, give me the vials of the medicine we have given. Because until the debrief, I didn't know. I thought the patient, despite me giving calcium gluconate, the patient has thin because of the hyperkalemia. And when I now went, another thought told me, just go now, this is a case, we are sorry about it. And the family was to come for debriefing, I think later in the night or early in the morning. But I again went and came back and said, everyone come, let's do a debrief. What went wrong? What went wrong? What went right? Can I see all the medications we used? Lo and behold, the vial. And that's when you realize how badly we need to improve the systems. So when people are talking about it and hyping it in the conferences, and you hear sound alike, look alike, you think, it's just a story. So I have 1,000,001 stories that I can tell, and I also have 1,000,001 success stories that I can give, where people just one intervention just kind of revives a patient. So that case always reminds me, when you say look alike, sound alike, you think it's a joke, but it actually works.
That does happen to me,
It happens, and you know it when it happens.
Wow, that has made me so sad. Anyhow, as we continue and proceed in surgery, there's so many people you look up to as a surgeon, as a leader in healthcare, as a quality person, as an author. Who will that person?
I think I just mentioned Atul Gawade, brilliant soul. Read him, all his books, Better, Complications, Being Mortal.
And try to get it, but I'm not into surgery, so...
Yeah, so he's a brilliant writer, he's a brilliant teacher, he's a brilliant surgeon. My late mentor, Professor Hassan Said, I don't know if you know him, passed on quite some time back. Very, very instrumental in my training. So maybe I can just highlight those two in the field of surgery.
So if today you were not a surgeon, what will you be?
Yeah, I keep saying if I wasn't a surgeon, I think I would be conducting the orchestra, like just listen to the play the violin and all the other instruments, and I'm just conducting. I do not. I play amateur level keyboard, so I'm hoping to just kind of upgrade on that or something like that. So I haven't stopped and thought, what would I do if I wasn't a surgeon? I feel like I would love to teach, so probably I would be in teaching. I love to kind of write impactful documents. So that says probably I would be in, policy generation, management firms or think tanks like that.
Yeah.
Such like. But no one can tell for sure. In science, no one can tell for sure.
So if the government of Kenya today picks Dr. Stanley to tell him now this docket of health in this country,
Amen, 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 amen. Right now, CS Nakumicha has already overtaken what I was supposed to. I would just go there. She has seen she's not going to be due with a Cuban contract. That would be the first thing, because I actually joined my colleague and saw an affidavit when my colleague went to court to say there's no way you can invite foreigners when they are Kenyans who are not employed and pay them better when they are Kenyans. So I joined on the strength that if I was given the same package that you're giving the Cuban consultants, I would probably leave my job and come. Probably no one has known that, but I remember signing the affidavit and sending it to Dr. Misango. Of course, the court threw it out on... No, Dr. Misango, the urologist, he's the one who had taken the case to court. He took the government to court for bringing the Cuban doctors. But anyway, that is what under the bridge. What I would like to do if I was CS would really to lobby the Council of Governors to lobby all the players in the sector to move the human resources for health back to the national level and have them managed under centralized body like the Health Service Commission or something like that. I have spoken about it, I have written about it in a peer-reviewed article. I feel that the devolution for health should have left human resources for health at the center or at the central level, because if devolution had happened before, probably I wouldn't have gone to Transmara. And if Transmara doesn't have enough doctors, so then who is going to go to Transmara? So what happens is you might get to a situation where you have one doctor in Samburu County or two doctors in Samburu County and 4,000 doctors in Nairobi. Yes, when you're talking about universal health coverage, you're talking about care of the populations based on their needs without exposing them to financial hardship. And therefore, if all the populations are not catered for properly, you get all the Nairobians have everyone, but the other Kenyans are just languishing in need. So we need to bite the bullet and take that bold move. It's not going to be easy, but I think it's something that I will do as the first order of priority.
No, somebody's listening and they have heard and they're not.
Are you? Okay.
What's your parting shot?
My parting shot has always been your health is your wealth. So for everyone out there listening, if you just have some ailment, you're just feeling unwell, just seek medical help. I see a lot of patients who come to my clinic who land on my table, and I just look at them and say, I wish they had come sooner, especially when you're looking at problems like cancer, because the sooner you present, the better the outcome. So what I would say is that we prioritize, much as the economy is pressing us left, right, and center. See how we can prioritize on our health also, check wellness checks, early intervention, etc., so that we can make it better for ourselves. For the healthcare providers, it is never too little, whatever you do, about quality. And quality doesn't mean expensive. It just means doing it right. Just do it right even when no one is watching. It goes a long way.
And before you finish, and it's a parting shot, but I want you to address all the male patients who are not able to do wellness checkup, especially for prostate hyperplasia.
The male patients in ICU, I know you're not hearing. The male patients at home, it is important to get that check. Even if it's once in a year, you think it is expensive, but just having a chat with the doctor and maybe just one blood test and one exam, just physical exam, will be more than enough to just tell you have a clean bill of health, or wait a second, just go prepare yourself and come, let's see. That for me is better than just saying I don't have money, this thing is too expensive, I'm not going. So for men from 40 going forward, karibuni, sisi wale tuko 40 and above, just once in a year, hata kama ni the October, which is the current month, prostate, breast cancer awareness. I've written before saying just make it a global health awareness month for everything. Just go and get checked. And getting checked is not just a list of tests. Just talking to the doctor, and you might find you might have some mental health issue. The prostate is okay. You might have some other problem. Just let the doctor just advise that. That will be enough.
What a better way to conclude this interview than Dr. Aru.
Yeah.
I like saying Dr. Thandi, and here is certificate my town. In a nutshell, what we've picked is get your wellness checkup, emphasize on quality, sound alike, look alike things. I know just statements of the boardroom, they're very fertile. And above it all, be an enthusiast of your good health because it's your wealth. That's all for today. Welcome back again next week as we get to know more about another profession, and may you have a blessed week ahead.